What you're describing, floater suffering patient, is a moving little shadow. It's in the vitreous. That is not the tear film, the cornea, the lens, the retina, the optic nerve, or the brain. It is something in that space. I just have to admit that, and just like I said, to concede that sometimes I'm just not going to be able to find it. It is more satisfying to say, oh, I see it, but I can't treat it. That's much more satisfying than saying, I can't see it, because I think that patient might say, well, I need to go to a better doctor. I need to go to somebody who actually can find this. Welcome to another episode of a master class for eye doctors in the management and treatment of eye floaters. I'm Dr. James Johnson, also known as the Floater Doctor. Today I want to talk about the 4-item checklist, a ridiculously simple to explain but functionally more difficult to effect checklist that I go through in my head when I'm trying to determine, is this person a candidate for treatment with the laser? This is particularly for the laser. And I say it's ridiculously simple. I had a patient last week who is a leukemia specialist physician from California. And we were kind of laughing and comparing and contrasting the different styles of practice. His is based on lab data and blood draws and recent published studies to try to come up with a treatment protocol, which can be very, very complicated. And mine is relatively quite simple. Mine is very visual. I don't rely on lab values or ultrasounds or imaging because I don't think that those are all that helpful. I'll explain why. So this is my 4-question checklist, and it goes a little something like this. The first question I ask myself is, can I see something? I know that sounds ridiculously simple, but you know what? Sometimes you can't. And this would be more so with the younger patients who might have some thin, wispy fiber or a little nest of some things. These might be microscopic, and they typically be very, very close to the retina. And the reality is the patient's resolution of what they see with their eyes is always going to be greater than what we see looking in. Maybe an example would be if you had a camera, and the picture kept, every picture that you took had a little piece of lint, in around the same area of pixels, and that's a little piece of lint on the sensor. And so every picture you take, no matter what you take, no matter what settings, there's always that little debris that's sitting on top of the sensor. Well, what you need to do is to take the lens off and blow that out of there, and take the little soft brush and wipe down that sensor and clean that off. Now, before you do that, if you take the lens off and you take a look in there, you might have a microscope, you have magnification, you might not be able to see that piece of lint. And we're both looking for the same thing, but the patient is always going to have greater resolution and see and describe that. So sometimes I just have to concede, I can't see it. I can't find it. What you're describing, floater suffering patient, is a moving little shadow. It's in the vitreous. That is not the tear film, the cornea, the lens, the retina, the optic nerve, or the brain. It is something in that space. I just have to admit that, and just like I said, to concede that sometimes I'm just not going to be able to find it. It is more satisfying to say, oh, I see it, but I can't treat it. That's much more satisfying than saying, I can't see it, because I think that patient might say, well, I need to go to a better doctor. I need to go to somebody who actually can find this thing. And so after I've told the patient I can't see it, I know I'm going to spend another half an hour explaining why and kind of explaining this whole thing. So first is, can I see something? Now, if you do see something, it can start, and to follow up on that would be number 2 on that checklist is, okay, I see something, but does this make sense? And that's where the real art and skill comes in. It's not enough just to see something and treat that something, because that floater that you see may not be the culprit floater. As an example, I had a patient, a young guy, come in, and I give a little rectangle and I say, this is your visual field. This is your visual field. Draw what you see. And he drew a little nest of something like that, kind of vague and ill-defined, but something in the center part of his vision. Now, he was a Chinese American. He had been to 2 doctors in Los Angeles, and he had been to 5 doctors in China. And he had been told various things. And like I say, if you go to one doctor, you know what's going on. Go to two doctors, you have no idea what's going on, because once you start having different opinions, it can start to get a little confusing. So he had been told that, yes, your floater is in the middle part, or is near your lens. He had been told that he had a posterior vitreous detachment. He'd been told, various combinations of different things. So, when I asked him to draw what he saw, he'd draw this thing, kind of ill-defined. When I looked in there, I saw a thin floater, actually relatively about that size and relatively about that position. So I said, I see something, check, I see something. But in my experience, because this was very thin and wispy, and because of its location, a bit off axis, a bit anterior, I didn't think that was the culprit floater. So does this make sense? Second question. No, this doesn't make sense. It doesn't make sense. And in fact, I looked in there and I'm like, are these other doctors out of their ever-loving minds? He hasn't had a posterior vitreous detachment. No wonder he's confused. No wonder he thought he was a candidate. No wonder when he contacted me, I was told I have a PVD. I was told my floater's in a good position. I'm like, you're 31 years old. If I were a betting man, I'd say you're probably not a candidate. But if you want to make the trip out here, I'll give it the old college try, or give it a fair evaluation and keep my mind open to it. I don't want to close my door to anybody. And so he did, and I said, I don't think that this is the floater. It's probably something back here. I said, but look, I get that you're distressed. I get that this is causing you great distress. And you've been told some various things that may make it seem like you're a candidate for treatment. I tell you what I'm going to do. Let me pick at this thing. Let me get my laser on this. Let me at least break it up, sever it, divide it, fractionate it, break it down to some smaller pieces. And it was very accessible and very gettable, and I probably got most of it on that first treatment. I said, but don't pay me. You're coming back tomorrow. Let's have you come back tomorrow. Let's have a conversation, which goes something like this. And I say, well? So he came back, and I said, well? And he said, it's still there. And I said, I thought so. I said, I didn't think that this was it. But the reason I did this is, I called it a diagnostic treatment, a treatment that diagnoses whether this is the culprit floater or not. I didn't think it was. Now, I could have just said, I don't believe this is the floater. I'm not going to treat you. And go about your business. And then he would have been very dissatisfied with that. He would have gone on to find somebody else who might fire a laser at that. Or I could have said, these are my fees. This is what I do. I get paid for firing the laser. And I could have done that and taken his payment. And he'd come back the next day, very disappointed. And now a couple $1,000s poorer without changing anything as far as his vision at all. I did this for him, knowing 99% sure I wasn't going to get paid for it. I did it so he could have some satisfaction, at least knowing that floater that was there, that was described by the other doctors, was not the floater. So, anyways, I did though come up with, and I thought about it a lot overnight there, and I came back that next day and he said, it's no better, and I said, well, I don't think there's anything else I can do. And I went back and I looked in there, and I think maybe I saw a little something closer to the retina, which made me feel like, well, maybe that's ultimately it. But I did come up with a more unified theory. I said, how is it that some of these doctors have said that you've had a PVD? It might be from having performed an OCT. Now, an OCT, an ocular coherence tomograph, gets very high resolution of this area right here. That shouldn't be there. Right here. The layers of the retina and about 0.5 millimeter in front of the retina. It doesn't image anything right here. And the doctors had done an OCT and said, you had a PVD. I think what may have happened is he didn't have a posterior vitreous detachment in the traditional sense of a complete collapse, where this outer vitreous cortex pulls away from the retina and you get this loose and redundant loose membrane in the middle part of the eye. I think what may have happened is he might have had a very slight partial separation of the vitreous right back here, creating a potential space between the retina and that vitreous cortex membrane, which is not in the process of separating. It might just pull away just a little bit and create this potential space that's called the premacular bursa. And that might be where he has something trapped in that space. So as the eye moves and this kind of builds around, it's kind of like pushing on both sides of a blister. You push on one side of the blister, this one elevates, push on this. So this might be kind of billowing back and forth, and that might be where he has some a small amount of protein debris trapped in that space, which might be responsible for his symptoms. So this is a long and complicated way of saying, does this make sense? In that case, it doesn't. I had another situation. This was years ago, but my patients have heard me describe this story before. This was a young, again, early 30s, a Japanese school teacher, came all the way from Tokyo, flew all the way from Tokyo, and she said, my doctors told me that my floaters are in the middle part of the eye, and she did. In fact, she had, when I asked her again, I'll give you the rectangle, the visual field rectangle, draw what you see. She drew this thing that was kind of like this, had a little nest in it. And I remember specifically had like a little divider off to one side. And I said, okay. And when I looked in there, I saw something morphologically kind of similar. So I went through my checklist of, can I see something? Yes, yes. Does this make sense? In this case, it didn't, and I'll tell you why. I went back and asked her, I said, this thing that you see, is it usually horizontally oriented? Well, yeah, it is horizontal. And I was looking at it, vertically oriented, and, there's nothing about the optics that would make something that is oriented this way, appear to the person this way. So again, similarly, I said, well, let's do a diagnostic treatment. Let's see what happens. So I did, and she came back the next day, and she's like, yeah, it's no better. And I said, well, that wasn't it, and it must be something. And I went back the next day, and maybe just wishful thinking, saw a little something there. So that's where the experience comes in. It's not enough just to see something; it has to make sense, and you have to think about floaters and floater shadows differently. I think probably my next episode is going to be on how to think about the shadows caused by floaters, the different optics involved. So to reiterate, we've got, can you see something? Does this make sense? That takes a lot of practice. That's the hardest part of it. Does this make sense? Third item is, what about the optics? What's going on? So, since we're delivering a cone of energy through this optical space, we'll talk about that in another episode when we talk about the physics of the laser and the optics and physics of the laser. We're trying to push this cone of energy through the optics. It has to pass through the optics of the eye, which means that there are some potential barriers, bottlenecks, I guess, sort of visual bottlenecks. One is, what is the quality of that front surface? Now, if people were to have, for instance, very, very dry eye, even enough to affect their vision, that's really not going to affect us at all, because we're going to use a contact lens. That contact lens is going to be coupled against the cornea, and there's going to be a gel or some sort of viscous fluid that's going to couple that up there. So even if they're going to have a little bit of irregularity of that cornea, particularly tear film, we're going to neutralize that with that contact lens. That's not too much of a problem. But what if they've had a lot of LASIK? Or a lot of corneal refractive surgery? Well, corneal refractive surgery will typically, there's a couple of versions of that. One might be radial keratotomy, where they have these radial incisions, all the way circumferentially around there. That creates scarring and irregularities of that corneal surface there. Again, that contact lens will neutralize some of that, but there's going to be some nearly full thickness scarring of that cornea. I can work through that. We can work through that. It's not a showstopper. It just, and many of these corneal issues are not contraindications to treatment. And furthermore, they don't increase the risk to the patient. That's very, very important to convey to them. But they do decrease the amount of energy and maybe the efficiency of that energy. So that just means that you might find yourself cursing under your breath a bit more than you'd like to while you're treating in frustration. So radial keratotomy, one of the first forms of corneal refractive surgery. But even with more current versions of for instance, PRK and LASIK, you're going to have a central zone, you're going to have a surrounding donut of transition zone. This is the treated central zone. This is the transition zone, and this is the virgin cornea here. So you're going to have three zones, and potentially, as you push that cone of energy through that area there, you might having to be pushed that cone of energy through 3 different zones. And what I found is you just tend to get maybe more of an irregular spread. My 2 focusing beams will be kind of dancing around each other. These focusing beams that we use run along the top and the bottom of that cone, and the one going through the top, original virgin cornea, might be slightly different. So you just find that you have to work a little harder to deliver that oomph, to try to deliver that energy. So again, doesn't increase the risk to the patient, but it does decrease the efficiency, and you find yourself a little frustrated with that treatment. So that's the cornea. Now, the next layer it has to pass through is the pupil. Some pupils just don't dilate very well. Younger people, you just put a little whiff of the smell of tropicamide around them, and their pupils open wide open. And the bigger that pupil, the more of that cone you can push through there, the better the binocular stereoscopic vision, the more you can push the light source off to the side. You just have a nice big area to work through. That small pupil, man, that is hard to work through. A small pupil, and this sometimes in diabetics, sometimes for whatever reason, people who've had cataract surgery, older people in their 70s or so who've had cataract surgery, sometimes that pupil just won't open. And you're trying to push that cone of energy through that small opening. Well, first of all, you're blocking a lot of energy, so the amount of delivered energy might be greatly reduced, but also that might block the focusing beams. So now you are having to rely on secondary and tertiary mechanisms of focus, which is a little disconcerting, or you might just have to work harder at having the patient move their head and move their eyes to get the floaters to maybe move a little bit more anterior. The more anterior the floater, the better the visualization, the better delivery of energy. If it's posterior, peripheral, or they just are very highly myopic and they have a relatively longer eyeball, those are going to be tough eyes to work with. And there have been some times where I'm like, I don't know, dude, like we could try. This pupil just will not dilate. We've done 3 rounds of dilation. We've been super patient with the time. That pupil is just not going to open up. Sometimes you can do surprisingly well, I just had a patient like that, and it was difficult to work through, and over the weekend he let me know that he was really satisfied, 95% improvement. I was blown away. I was really, really surprised. So that's one area. The other is the optics of the natural lens, which could be cataractus, which means it's cloudy or irregularly irregular, and so the quality of an advanced cataract might mean you could try, but be very kind of low expectations. And there's been a few instances I do remember where I've said, well, let's just try, and I was just firing away, and I was just like, I don't know. Like, I think ultimately we might just have to just put laser treatment on the back burner, and when you have your cataract surgery, afterwards, you come back and we'll get after it. And I've had a patient like that just a few months ago who did come back and was much, much more treatable. So sometimes you just have to say the optics are just crappy. I just can't work. I can't work through those optics. Now, instead of a cataract, maybe they've had cataract surgery and they have a perfectly clear intraocular lens replacement in there. Well, great. Now you have a perfectly clear lens to work through. But there can be some problems with that. First of all, the newer lenses have a diameter of about 5.5 millimeters, which is smaller than the natural original equipment manufactured lens. And that can be a bit of a bottleneck. Usually not a problem, but it's something. I have gone off, both my patients and in a video, about the multifocal lenses that have these concentric grooves cut into them. It's a Fresnel style lens, and each alternate groove will give you an alternating focal length, multifocal. So in other words, as light is entering into this optical system and you have a bunch of these grooves cut in there, that means that you have one focal point out here, you have another one in a different location, which means that you never have your vision 100% focused into one location. Now, that means you can see pretty well for distance and pretty well for near, but you're not getting 100% of the light rays for up close or for distance. So it's a bit of a trade-off. Life is full of trade-offs. It's just another one. And some people are willing to take that trade-off of a decreased crisp quality of vision for the increased function. So that's okay. But working through those multifocal lenses, man, it is a challenge. The vision is not crisp and clear. The energy is decreased. It's much harder working in the back part of the eye than is the front part of the eye for similar reasons. I am not a big fan of these lenses. But hey, they're popular. A lot of people are being upsold on these multifocal lenses and are coming in with floaters with these lenses, and I just have to take it like a man and just say, well, you know what, I don't have a choice in the matter. I didn't cherry pick you. You chose me. I just buckle up and go for it. And again, it doesn't increase the risk to the patient. No, let's revisit that. Let me just say broadly, it generally doesn't increase the risk to the patient, but does decrease the efficiency. But I hesitated there for a moment because what if you are working on something that's a little further back there? And the question is, if there actually is two focal points, are you thinking that you're focused on something that might be kind of at the margins, but there's going to be some energy being delivered further back? So in the case of multifocals, I think you have to take that margin of safety posteriorly and just create an even greater, further away from the retina margin of safety just because of that uncertainty. It isn't like you see two focusing beams and you can gauge that. You're still seeing generally one, and it can be a little visually confusing. So probably err on the side of keeping your distances a little bit further away from the retina. And then you have a posterior capsule. So for those who aren't eye doctors, you have the lens capsule. With cataract surgery, they remove the front part of that capsule, and we're kind of looking like this. They remove the lens, they put an implant lens in there. This back capsule there, the posterior capsule, can often get clouded over, and so a posterior capsulotomy is using a YAG laser just like this to break open that posterior capsule. Sometimes the doctors will create a small capsular opening. This might be very sort of clouded around that, so you have a functionally small aperture, kind of like a 4-millimeter pupil to have to work through. You have a functionally small posterior capsule. Again, just another barrier to have to work through. Usually you can. There have been a few times where I was like, describing the situation to the patient. I'm like, I've got the YAG laser. With your permission, I'd like to open up that capsule just a little bit more. Not hugely. And it might be the second day I've treated them. They'll come in on day number 1, and I'm treating them like, it's like, just seems really difficult. I'm not sure how much effect. And then on day number 2, I'm like, may I please open up that capsule a little bit? And they're like, sure. And then I do. I'm like, what a dramatic change. It just dialed things up greatly. So sometimes you do need to open up that capsule a little bit, and that does make a huge, huge difference in the efficaciousness of that treatment. So where are we? Optics. That covers most of the typical optics. Would things like nystagmus matter? That's not really optics. We'll just stick with that. The ideal patient will be clear cornea, clear natural lens, huge pupil, no previous refractive surgery, muckety-muck. Just this is all kind of virgin and clear, so you don't have to think about it. You can just kind of work past that. Okay, so that's the optics. That's third is optics. The fourth consideration is, we see something, 1. 2, it makes sense. What I'm seeing is consistent with the patient is describing. Third is the optics are good or good enough. The last item is safety, and this has to do, just like real estate, location, location, location. So that is, where is this object of regard? Let's say, for instance, patient just had a sudden onset floater Saturday, and they're here Monday saying, I live right here in Dallas-Fort Worth. I had this thing happen. I saw you on the internet. I saw you had a spot available. Here I am. This thing is driving me crazy for the last 48 hours. And let's say they just have a new, and still having flashes of light and such. So let's say that their vitreous membrane has just kind of started to pull away. They've got a nice Weiss ring. The membrane is still starting to pull away. You're still getting some flashes of light out here. And let's go through our series. Can I see something? I look at them, yeah. Oh, yeah. And by the way, draw a picture, and they're like, oh, I've got this thing and this kind of membrane-y thing up there. Okay, do I see something? Yes. Does this make sense? Yes, absolutely. That ring thing that they're seeing is very consistent with what I'm seeing. This is the culprit. And I can say that with essentially 100% confidence. Everything makes sense there. Third question is the quality of the optics. Well, virgin eye, clear cornea, clear lens, nice big pupil. Everything's great, right? And then lastly is safety. Well, this is too close to the retina and the optic nerve. I don't feel comfortable treating that. And so that last one doesn't get checked off. It's too close to retina. I don't feel safe treating. But give it some time. Give it at least a month. Over the course of that month, that whole membrane complex will likely move away and then find its stability. The flashes will be gone. The PVD will be completed. Some of that dense, dark ring that they were describing will have moved a little further away. It might actually be less noticeable or less bothersome. Or they might say, yeah, a month ago when that first happened, it was denser, it was darker. I just thought but it's a little bit softer. I still see the ring. It still bothers me, but it's not as dense and dark. Well, what if you have something that's even smaller or thinner? Smaller or thinner that does move away, that might, over the course of that month, that might become a lot less noticeable and to the point where they don't really need treatment. So that actually is good for the patient to defer and give it a little bit of time to see how this thing establishes itself and actually potentially decreases in symptoms. But let's say that that's still bothering them. Well, now it's moved into a safe treatment. So when we go through our 4-question checklist, now they've moved into you are now a candidate for treatment, and I feel more comfortable with it. I guess since I kind of brought this up, maybe this would be good for another episode, which is maybe some of the medical legal aspects of this too. Let's say that this has moved into a treatable location, but some of that vitreous cortex membrane is still attached out here in the peripheral retina. That's the sources of their flashes of light. So where this membrane is kind of peeling away, that's where it's pulling and tugging on the retina. That's where they're getting their little arcs and flashes of light, the flashes that go along with the floaters. Now, is this treatable? Yeah. So let's say they've gone to their local doctor and the local doctor says, give it 6 months, it'll get better, your brain will get used to it, it'll drop out of the way, you'll neuroadapt or whatever sort of platitudes that they throw out there. But they planted this seed of something about 6 months or so. And let's say they come to you and they say, oh, but don't do the laser, that's crazy, dangerous. You don't want to be doing that. Don't you think if that worked, we would be doing this too? But then the patient goes online and they find you, they find me, and they come to me and I'm like, oh, I can treat that. Oh, Weiss rings are my favorite to treat. They're in a great location. I'd feel great about treating this. But their vitreous still hasn't completely detached and separated. That's why they're still getting some flashes of light. Is the laser going to cause a problem? I don't think so. I don't think the laser causes traction. The laser may break up that membrane. There might be less pulling and traction. But let's say that you do treat that, and just with the natural course of that membrane continuing to pull away, let's say that it does separate and they have a little small hole or tear. Now they go to their local retina doctor and they say, I've had a worsening of my floaters, lots of thousands of little specks all over the place, maybe some hemorrhage, and the doctor takes a look in there and says, oh, you've got a retinal tear, a retinal hole. And the patient's like, well, I did go see Dr. Johnson and I had a laser treatment. And they're like, oh, the laser caused that hole. And they're like, dang, why didn't Dr. Johnson tell me? Dr. Johnson, and now you're in an awkward position of sort of defending what you did when the natural course of this was most peripheral retinal holes, tears, and detachments occur from the vitreous separating. Why were you in a rush to treat them? There's no treatment outcome advantage of early treatment. So my general rule of thumb is someone says, this thing just happened yesterday, I'm ready for treatment today. I'm like, hang on there, bucko. Let's give it a little bit of time. Let's wait for the flashes of light to go away, or mostly go away, or at least enough time to where it's kind of established itself as getting out of your window of time where you're at risk for retinal hole, tear, and detachment. Let's give it a month or so, or maybe even longer. And if the doctor planted the seed of it's going to get better in 6 months, I say, come back and see me in 6 months. There's no rush for this. It's not going to change anything that I do. It's not going to change the outcome. But also that patient might need to be certain that 6 months has passed and it has not gotten better, that they're still quite bothered by that floater. So sometimes you kind of have to play that medical legal protective posture game as well. And like I said, there's no advantage to early treatment as compared to infection, inflammation, cancer, things like that. So that's that. Those are the 4. It is ultimately a judgment call to treat. With time and experience, you can get better about thinking about floaters and the shadows that they cause and the patient's symptoms. And sometimes I'll treat something and I'm just not quite sure, and I'll just let the results declare the value of that treatment, as I described in a previous episode. But those are the 4. It doesn't rely on imaging. I have not found imaging to be helpful. It doesn't require on the patients bringing in the previous chart notes, medical chart notes from their previous doctors. I haven't found that to be very helpful. Regardless of what they've been told by their other doctors, you've had a PVD. Sometimes they haven't. I found doctors have equated floaters with PVD, and that's not true. The PVD is an anatomical separation of the vitreous cortex membrane away from the retina. It is something you don't have, or you're in the process of it, or you're finished and completed with it. It has nothing to do with floaters. Well, it does, but you can have floaters without a PVD. You can have floaters with a PVD. They're not in equivalent terms. This is the art and the skill of treating floaters, and it comes with experience. And their only way to get experience is to do a lot of them, and that's where I have a bit of a first mover advantage, I suppose. I've been doing this for 18 years. My entire practice has been the treatment of eye floaters. This is all I do. And so anyways, if you are a floater suffering patient and you snuck onto the master class and you're just out of obsessive curiosity, welcome. There's no shame in that, doing your due diligence and research. If you're a eye doctor, ophthalmologist who is interested in treating floaters, I hope you learn a little something here. If you've been treating floaters, you might still learn a little something, or at least get my perspective on things. If you're an optometrist, it might just help you with the management of treatments the management and guidelines and guidance for the patients that are suffering their floaters, to learn a little bit more of the options besides just doing nothing or the vitrectomy. I have many, many, many more episodes in mind, and I hope they'll all be very helpful and useful and utilitarian. If you think that you might want to watch more of these, you can subscribe, you can hit the notification bell, you can hit like. All of those will help other people find me by getting my videos in the YouTube recommendation algorithm. I appreciate it in advance. So thank you for watching, if you made it this whole way through. And until next time, have yourself a great day. It's been a pleasure.